And welcome back to part 2 of 3 in our Dementia and Cognition lecture. In this lecture, we're going to discuss our chronic disorders. We are starting in page 158 of your course notes packet. Now, when it comes to chronic disorders, we will always consider dementia as our main chronic disorders, but there are quite a few different types of dementia. So the goal for this shorter section is to really discuss the differences between the chronic types of disorders. Now, the most common type is Alzheimer's, but you also have some vascular dementias, so multi-infarct dementias, Parkinson's associated dementia, dementia with Lewy bodies, frontotemporal dementias, and frontal lobe degeneration, including Pick's disease. The main symptoms with all of these disorders are actually very similar. You have depression as a symptom, anxiety, paranoia, inappropriate social behaviors can occur, anger, emotional perseveration, delusions, and then confabulations or storytelling. So let's discuss each one. Now, multi-infarct dementia is the first chronic disorder that we're going to discuss. Multi-infarct dementias are usually a much more rapid onset, but not like our acute symptoms, our acute dementias, which can happen from one day to the next or within a few hours. You will have this episode of the patient being completely fine, and then all of a sudden have a significant decline, and then that patient averages out. Multi-infarct dementias can occur, are mostly in younger individuals, and they do progress in a very stepwise fashion, right? You have this abrupt worsening and then a plateau of function. You can have a little bit of an increase. The patient often has neurological deficits, so it is basically an infarct or kind of stroke-based or TIA-based dementia changes that can occur. So you might have some paresis or some decreased in mobility, some paresthesias that can be part of the physical symptoms. It occurs in about 14 to 20% of patients with dementia, and another 16 to 20% have actually a combination of Alzheimer's disease and multi-infarct dementias, which will progressively increase the worsening of the cognitive changes that can happen with that adult. Now, multi-infarct dementias, the medical history is really important. Hypertension and uncontrolled hypertension and diabetes will often lead to an individual being much more at risk for the multi-infarct dementias. And you also have those individuals with potential generalized atherosclerosis. Now, it is irreversible brain damage that results from an ischemic injury, and it's caused by either an embolus or bleeding, again, so related to TIAs or CVAs. Normalization of the blood pressure is the most effective intervention known for this type of dementia to stop that progression from occurring. Dementia with Lewy bodies is the next disorder that we have that we're going to discuss. It's associated with visual, spatial, and executive dysfunction. So these individuals have a very tough time staying at home on their own and being able to safely manage cares on their own. The patients present with hallucinations. They have spontaneous Parkinsonism-like behaviors, so decreased in mobility, decreased, freezing of gait, things like that. They also have alterations in alertness and attention, so they might be hypo or hyper alert. They might not be able to pay attention as well. Now, visual hallucinations is really the key factor, and those hallucinations can actually be quite severe. And what we have to remember is the medications that are typically used to treat hallucinations with other types of dementia, and also the medications that are used to treat agitation that's associated with other conditions often don't work in people who have dementia with Lewy bodies, and the medications can actually exacerbate the symptoms. So it's very important that that the medical professionals diagnose the individual with dementia with Lewy bodies so they can get the appropriate medications and those hallucinations don't get worse. Pick's disease and frontotemporal dementias, we're going to combine them together. They're difficult to differentiate from Alzheimer's disease. The presentation includes personality changes. So people will have some changes in their personality. They might have some language impairments. They're also going to have some difficulty with apraxia. So apraxia is that inability to execute purposeful or learned movements. So, for example, handing somebody a brush, a hairbrush or a comb, you would know that that's to comb your hair, so you would automatically bring that up to your head. So that motor apraxia, that you can hand that person that comb and they would not know what to do with it. Impulsivity can also be a symptom. So this is very important when it comes to safety. They might be impulsive in their safety and not remember those safety pieces when it comes to mobility. Apathy, they might have a carbohydrate craving. Mania, grandiose solutions can also happen. Apathy is kind of the lack of feeling, emotion, interest, or concern. So just in case you weren't aware what that apathy was. Now, it is worthwhile to differentiate Pick's disease from other dementias. So most common class of pharmaceuticals utilized to treat dementia-related symptoms, so which are acetylcholine enhancers, they may not help that patient with Pick's disease. So these patients may have some adverse reactions to these medications. That person with Pick's disease could also, if you address this and it's caught early enough, you can limit the changes that can happen, the cognitive changes. So it's really important for that person to get diagnosed appropriately. Again, not something that we do, but it's important for us to kind of know and understand the differences between these chronic dementia disorders. A probable diagnosis of disease, Alzheimer's disease. Now, Alzheimer's disease is truly diagnosed when the person has passed away and you have to do a biopsy of the brain. So if your person is alive, of course, it's a probable diagnosis of Alzheimer's disease. That's really what the diagnosis is. So you see a presence of memory impairment and one of the following. So you have that aphasia. So aphasia is that disturbance of the comprehension and formulation of language. We talked about some of the speech things. So you start having some aphasia things that happen. Apraxia can occur, right? So apraxia, again, is that inability to execute the learned purposeful movements. You also have agnosia. So agnosia is the inability to identify an object. So think back to some of those cognitive tests that we have done, and remember there's a couple of them where I show you a pen and you have to tell me what that is, right? So that's agnosia, being able to identify some of those common objects that you know. There's also disturbances in executive function that occur when it comes to Alzheimer's disease. So that executive function, once again, is that working memory. It's the mental flexibility. It's the ability to control yourself, right? It's that internal self-control. It's the internal filter. And that grows and improves as you get older. So, but executive function is the CEO of the brain. So these things all work together in combination to be able to allow an individual to be independent with all of their skills. Now, there is significant deficits in the ability to do daily functioning and a representation of a decline from previous performance. So deficits that impair daily function and represent a decline from previous performance. You'll see that in individuals with Alzheimer's disease. A gradual onset of continued decline also needs to be seen in that individual. Cognitive deficits have to also be unrelated to any other known central nervous system conditions. We have to rule out delirium. We have to rule out any sort of medical conditions that can induce cognitive decline or any substance-induced condition. So to be able to be diagnosed, we have to rule out a lot of different things. And the cognitive deficits cannot be attributed to other psychiatric conditions, such as schizophrenia or major depressive disorder. So individuals have to go through quite a bit of basically special test and differential diagnosis to then be diagnosed with that probable diagnosis of Alzheimer's disease. Now, Alzheimer's disease is the most common form. There's about 50 to 60% of the reported dementia cases that are diagnosed that are Alzheimer's disease with that elderly population. It is the most common form of dementia. It's linked to physical symptoms such as urinary incontinence, gait apraxia or motor apraxia. About approximately 4 million Americans are currently diagnosed with Alzheimer's disease, and we're expected to see that number increase significantly by 2050. Now, it is the most expensive condition in the nation if we look at it. So these are statistics from just a few years ago. The direct cost to American society for caring those individuals with Alzheimer's disease, it's estimated at $214 billion in 1 year. The estimation is 1.2 trillion for these cares, right? So it takes a lot. And Alzheimer's disease is ultimately characterized by a couple of things, right? There's a slow onset of increasing intellectual impairment. There is that disorientation. There is memory loss. There's a reduced ability to reason and make sound judgments. There's a loss of social skills, and then development of regressed or antisocial behavior that can occur. And that can be really difficult for family members to deal with. Now, Alzheimer's. With Alzheimer's disease, early diagnosis is key, right? Because you can initiate the process of patients and family adapting and managing to the disease symptoms. So it typically begins, patients begin with some short-term memory deficits, and they'll progress to severely regressed behavior, an inability to learn or remember new tasks, and then the loss of the ability to perform ADLs. So again, it involves multiple areas of cognition. It's usually gradual and progressive, but that progression is really slow. Now, one of the phenomenons that is unique to Alzheimer's disease is a term called sundowning. So sundowning is increased agitation in the late afternoon and early evening in individuals with Alzheimer's disease. Again, it's a phenomenon that's unique to Alzheimer's disease stages 2 and 3, and it's characterized by restlessness, overexcitement, and increased hallucinations and agitation in that early afternoon to early evening time frame that happens with individuals with Alzheimer's. Now, let's talk just a little bit about the pharmacological interventions because they can impede symptom progression and significantly improve quality of life in older adults that have been diagnosed with Alzheimer's disease. So there's two types of Alzheimer's disease treatments that are available. The first one is acetylcholinease inhibitors. These increase the amount of acetylcholine in the brain. It's a chemical that's important for memory and learning. So you have medications like Aricept, which is provided in all stages of Alzheimer's disease, Exelon. It's utilized to treat mild to moderate Alzheimer's disease, and Razidine. It's approved to treat mild to moderate disease. The glutamate pathway modifiers, so the medications like Namida, right? This is another chemical in the brain that's important for learning and memory. So Namida is currently the only drug of its type that's approved to treat moderate to severe Alzheimer's disease. Now, because these two types of medications work in very different ways, taking them together can be very beneficial. So again, you want to start these medications as early as possible. And so the combination therapy is what we see a lot of our patients being able to take. Now, you see at the bottom, there's significant mobility side effects, especially with the acetylcholinease esterase inhibitors. They cause falls, decreased in mobility, impaired balance. It is very important for patients with Alzheimer's disease or any sort of cognitive deficits that early on we really work on balance training and strength training to counteract some of the effects of the medications are going to do. So again, there are significant mobility side effects, and so you might see individuals that start with these medications, and this could be one of the main factors that the person could be falling or having balance impairments. So very quickly, let's discuss some of the the stages of Alzheimer's disease. So that early stage is that stage 1, where you start seeing some mild memory deficits, forgetfulness, difficulty with novel or complex tasks. You might start seeing some moodiness, so a little bit of behavior and personality changes, hypochondriasis, so they might start thinking that something's wrong all the time, some disorientation of time, lack of spontaneity, poor judgment. They might be blaming others, sense of helplessness. Now, the stage can last 2 to 4 years, but it changes for everybody. So our PT treatment focus at this point, we want to maintain physical fitness, right? Balance, strength, aerobic, providing as much neurosensory stimulation as possible to improve functional capability. Nutrition, minimizing drug use, right? That's also a focus. Looking at the environment, making sure that that environment is structured, is safe, providing emotional support, working with the patient and the family to start discussing some potential future plans. And the emphasis is really on the prevention of falls. Now, that PT treatment and focus is the same for that middle stage or stage 2. At this point, you will start having some moderate to severe objective memory deficits. You're going to have disorientation to time and place. You might start seeing some language disturbances. You will start seeing some of that motor apraxia that we've discussed previously. Personality and behavior changes start becoming quite inherent at this point. This person that's in that stage 2 will start requiring some supervision because there are going to be some significant safety concerns that start popping up. So that person usually in the healthcare system is in that healthcare system at this point in one way or another, whether it's a group home, whether it's day programs, nursing homes, hospitals, etc., because they start having some significant unsafe behaviors, and that constant supervision is required, right? Might see some paranoia, some hallucinations, physical abusiveness can start happening with that person at that point. Sleep disturbances also become inherently apparent at this point, as well as incontinence, and this could last several years. In stage 3 that's termed the late stage of Alzheimer's. So intellectual functions at this point are virtually untestable. Any sort of cognitive changes or cognitive tests the person just won't be able to do. Verbal communication at this point is severely limited. They're incapable of self-care. They're going to be incontinent of both bowel and bladder. They're going to have increased irritability. You might start seeing some severe anorexia because they forget to eat. They're just not eating at all. You might see some writing postures. There's no time limit for this late stage. There is a terminal stage, stage 4. At this point, that person's unaware of the environment. They might be mute. They're usually bedridden. You might see some joint contractures, some pathological reflexes can return, myoclonus. So that's where some of the theories of regression are from when it comes to the dementia pieces. Now, there are some other associated coexisting neurological disorders that you might see. So increased tone, seizures can happen, movement disorders, and gait disorders. So our treatment within these late stages is again to try and maintain as much physical fitness as possible, providing neurosensory stimulation to improve that functional capability, nutrition, environment that's structured and safe, emphasis in the prevention of falls. And you notice it's really the same for the early stages to the late stages. So just keeping some of those in mind. The physiological changes, anatomically, the gross atrophy of the cerebral cortex and the hippocampus is really a big thing that happens. And the hallmark physiologic sign is the presence of the senile plaques made of amyloid beta peptides in the brain cell. And that's, again, you can only identify that through biopsies after death. Now, there are some neuromotor changes that happen with Alzheimer's disease, and it's important to keep these in mind because that's what we're going to treat early on. So individuals could have balance problems, gait difficulties. They might start shuffling gait. They might have fear of falls, motor impersistence. So these are things that we are going to constantly address. Apraxia. Again, that's that poor motor initiation. So working on addressing some of these early on, agnosia, poor object recognition, ataxia, which is motor incoordination. So they might not be able to put pieces together, and that's going to impact balance. And cognitive impairments, right? So that poor judgment, memory deficits, emotional lability, and orientation loss are big neuromotor changes that happen. So here's the checkpoint for you, just for kicks. We're going to put your music on. Choose the best true statement. We know that acute chronic dementia is different. That depression, the person's going to be in the hypo side of alertness. Acute disorders are not Alzheimer's. Those are chronic disorders. And so our accurate, true statement is acute dementia disorders are potentially reversible, while chronic disorders lead to irreversible cognitive changes. So hopefully you got that at the end of section 2.